Good evening, everybody. Sorry for the couple of minutes late start. We had a little bit of technical difficulty. Hopefully this one's going to work. So we apologize for being a few minutes late, but thank you so much for joining us in this Facebook Live event tonight at Holy Cross Jordan Valley. I am Dr. Kevin Sagers. I'm going to be leading us through this discussion tonight on this Facebook Live, and I'm very grateful for everybody that is attending tonight. Please feel free to leave comments and questions as we go through this educational event tonight, where we're going to talk about advancements in the treatment of knee osteoarthritis. So we're grateful to have you here. Just a little bit of information of what we're doing with this Facebook Live. We want to occasionally have these on social media through Facebook Live, where we can have professionals and specialists like myself come on and give educational content to our community. We think that education is important. It's important to know what different things can cause different problems and what options there are for you out there, and who in your community can help you with those options. So we're excited to be doing these educational series. Tonight we're talking about orthopedics. We're talking about knee pain, as I said. Again, my name is Kevin Sagers. I'm an orthopedic surgeon. I work here at Holy Cross Jordan Valley and Holy Cross Mountain Point Hospitals with a specialty in hip and knee osteoarthritis and the treatments that I provide for those. I'll introduce myself a little bit more in detail here in just a minute, but I want to give a little bit of an outline of what the plan is for tonight. So I'm going to talk for about 15 to 20 minutes, just kind of giving some educational content about arthritis and the treatment options. As I'm talking, if anybody has comments or questions that they want to write in, we will be receiving those throughout this live event. And after I'm done with my little educational speech or content here, we'll take time to answer those the best that we can. So please interact with us, write in your comments, and we will answer them. In addition, this will be posted to the Holy Cross Jordan Valley Facebook page here, and you will be able to continue to answer or write in questions. We will go back as those questions come in and try our best to answer them as well. Obviously, if you have questions that you want to discuss face-to-face, we'll give you our clinic information at the end, and you can always call and set an appointment. I'm happy to see anyone and talk about any of these topics in person as well. That's my job. So anyways, again, I'm Kevin Sagers, orthopedic surgeon here at Jordan Valley. I'm a fellowship trained adult reconstruction specialist. That means I focus all of my time, energy, and effort in my practice on hip and knee pain and the treatment of those, especially hip and knee arthritis and joint replacement. What does a fellowship mean? I spent an extra year studying this, doing this surgery under the supervision and tutelage of some of the best in the country out at Wake Forest University, and they gave me their tips and tricks, and now I get to use those to help other people. Before I get into the educational content here, I want to give two disclaimers. The first is that nothing that I say here can be or should be construed as personalized health advice. This is for educational purposes only. The only way that you can receive personalized health advice is to see a medical provider and discuss your own history, symptoms, and treatment options with that medical provider. So nothing I say here can be construed as personal medical advice for you. The second disclaimer is, if I mention any products, procedures, or anything that I do just in my own practice, that is not to be construed as an endorsement of Common Spirit or Holy Cross Jordan Valley as an organization. The way I practice medicine, the way I do surgery, the products that I use and everything is my own preference and doesn't represent an official endorsement from the organization itself. So keeping those two things in mind, I'm happy to give my opinion and educational content here through this platform today. So first, let's talk a little bit about knee pain. Knee pain can be for a variety of reasons, actually quite a few reasons. You can have muscular knee pain, tendon knee pain. You can have cartilage damage or tears, such as the meniscus, or a ligament like the ACL. You can also have arthritis, which is more of kind of a wearing down of cartilage and the resulting inflammation. So there can be a lot of reasons why you can have pain in and around your knee. To tease out what is causing those issues and those symptoms, we need to have a very thorough conversation regarding how the pain started, where it is, when it's worst, what helps, what doesn't, and what things have been tried in the past, along with imaging like x-rays and sometimes even MRIs. So it's not something that I can just, someone can tell me my knee hurts right here when I do this, and I can say it's this. But there are a lot of common reasons why we can have knee pain. One of the most common reasons is osteoarthritis. We are seeing a higher prevalence of osteoarthritis in our day and age. I joke with patients all the time that 100 years ago, they didn't really have as much osteoarthritis, but the key factor there is their longevity. Their lifespan was much shorter. Most people died in their 50s and 60s 100 years ago, whereas today we're living into our 80s, 90s, and even into our hundreds. So things wear out, and things can hurt when they wear out. So osteoarthritis is a major cause of knee pain, especially in the aging population and throughout the world, not just the United States. What osteoarthritis is, it's the wearing down of the cartilage on the end of the bone. So when we're young, in our teenage years and in our early 20s, so long as we haven't had a major injury or anything, the end of our bones is coated in a nice thick layer of cartilage. And cartilage is a soft, spongy pad on the in between the two bones there. When we're young, it's full of water. It's this nice squishy pad. As we age, what happens is the water content of that cartilage starts to go down. It's just a part of genetics, unfortunately. That happens in everyone as we age. And then again, according to genetics or other factors, that cartilage can start to wear away when that fluid isn't as present in there. And that process is called osteoarthritis. In some people, it progresses quite quickly and even at a young age. In others, it really never even presents itself. So a lot of the main driving factor is genetics, actually. There are a lot of other factors that play a role, but that's kind of the process of arthritis. Now, the body can recognize that something is going on with that cartilage as it wears away. Unfortunately, the body tries to send inflammation there, like it does anytime it's injured in any other spot of the body, to try to heal it. But there's not a mechanism in our bodies to rebuild that cartilage or to kind of inject more water into that cartilage or things like that. So you end up with inflammation in the joint that causes pain and soreness and swelling and all the symptoms that come with arthritis. But there's not really a fix for it naturally, unfortunately. So that's why it becomes this cycle of pain and inflammation and swelling, and it continues to progress throughout life. So that's where we come in as orthopedic surgeons, is we try to stave that off. We try to treat the symptoms as much as we can, and if it comes to it, we can even surgically remove that cartilage and replace it with man-made materials to recreate that surface on the end of the bone and hopefully get rid of those annoying symptoms from the arthritis and improve the quality of life and decrease the pain in that joint. So we're going to talk about those treatment options a little bit now going forward. The first and most important treatment option is prevention, right? An ounce of prevention is worth a pound of cure. So living a healthy lifestyle, being active, moving your knee, eating healthy, keeping a healthy weight, all of these things will stave off that cartilage wear and tear. The cartilage actually gets nutrition inside of the knee from the fluid that is normally inside of the knee. The way you get new fluid inside of that knee is actually by movement. So if you want your cartilage to have the proper nutrition and not wear away, you need to move that knee. And so physical exercise and activity is really good in terms of staving off arthritis and its progression throughout our lives. However, once it's there, like I said, it becomes this slow and progressive process throughout our lives, and in some people it progresses to the point where it can be quite painful. So things that we can do, we can consider physical therapy, exercises, and things to try to get that knee moving again, get new nutrition in there, and hopefully calm down that inflammation. That's always good to consider. We can consider injections. We have different types of injections that we can use for arthritis. The most common that people use is a steroid injection. A steroid is an anti-inflammatory, and so its purpose is to be put inside of the knee to decrease that inflammation inside of the joint. There's another type of injection called hyaluronic acid. People refer to them as rooster cone injections, gel injections, lubrication injections. They have different brand names that people will know sometimes. And those hyaluronic acid injections, the way that they work is the mechanism is to try to inject a substance that is actually normally in our knee, called hyaluronic acid, that helps to rehydrate that cartilage. So those injections can be somewhat helpful in early stages of arthritis because the damage isn't all the way done, and we're trying to slow down the progression. Both steroid and hyaluronic acid injections, though, it's important to keep in mind that they are not growing new cartilage, they're not reversing the process of arthritis, and they are just sort of temporary measures to hopefully decrease pain, increase function, and slow down the progression of the arthritis. Other injections exist out there. Some patients have heard of platelet-rich plasma or PRP injections, mostly because professional athletes will have ailments and they'll go get PRP injections and say that it healed them and things. What platelet-rich plasma is we draw your blood, we actually spin your blood in a centrifuge, and we extract just a portion of it called the plasma that has a high concentration of platelets in it. Platelets in our blood actually they carry powerful anti-inflammatory components, and so if we inject that portion of your blood back into the joint, it can create a powerful anti-inflammatory effect. Those injections actually, if the blood is prepared right, the recent evidence, the scientific evidence shows that they're quite effective in decreasing pain. Again, they're not going to reverse arthritis or grow back new cartilage or things like that, but they can be powerful anti-inflammatory injections. The unfortunate part is, right now at least, at the time of this recording, insurance companies don't commonly pay for those injections, and they can be sometimes quite expensive for a lot of patients, usually anywhere between $75 and $150 per injection, depending on what machines they're using to prep the blood and things. So sometimes people are phased out of that option simply because of the cost involved. But that is an option, and there is some evidence out there that shows that it works. Some people ask about stem cell injections. Stem cell injections for knee arthritis were a quick flash in the pan fad. Theoretically, the idea was intriguing about injecting stem cells into arthritis and hoping that they could grow back new cartilage. Stem cells are cells in our bodies that they start off as a stem cell, and then if they have certain signals, they can turn into different types of cells, whether it's bone or cartilage or muscle or things like that. Unfortunately, when you just take stem cells and inject it into a joint, they don't have those signals, nor do they have a scaffold to go and attach to turn into cartilage cells. And they were also absurdly expensive. And unfortunately, although it was a good idea theoretically, the evidence showing that they provide any type of long-lasting relief, and certainly any type of cost-effective relief for arthritis, just never showed up. So we don't really recommend stem cell injections for arthritis these days. That was a fad that came and went. So those are the different types of injections that can be done for arthritis, and there's options out there for them. Above injections, there are some other non-surgical procedures that can be done to help with arthritic pain, especially arthritic pain in patients that are not good surgical candidates. I can think of a patient, that I saw once. He was 95 years old. He'd lived his life, but he complained of knee pain, and he wanted to try to stay as active as he could. Unfortunately, he'd had several myocardial infarctions or heart attacks throughout his life and things like that. It just wouldn't have been safe or wise to do surgery on him. So what we recommended for him was actually called a genicular nerve ablation. That means burning the sensory nerves around the knee. that transmit the pain to our brain, saying that arthritis hurts. And if we can numb those nerves by this ablation procedure, sometimes we can decrease the pain from the arthritis enough that a non-surgical candidate like that patient could experience enough relief that they could still go through their day and functioning without having surgery. If all those types of treatments are not doing the trick, if you've tried those things and the pain just keeps returning and it's limiting, it wakes you up at night, you can't do the things that you enjoy and live the quality of life that you want, then oftentimes the conversation of treatment turns to surgery. Surgery in the case of arthritis is some form of knee replacement. Knee replacement is a procedure where we actually resurface that end of the bone where the cartilage used to be with metal and plastic. Now, I'll show you this model that I have of a knee replacement. Many patients think that a knee replacement involves lopping off huge chunks of bone and replacing it with these big metal prosthetics. That's been a misconception about knee replacements. I'll take off this plastic model here of a knee replacement and show you about how big and how thin the implant is. So it's really just resurfacing the end of the bone with a metal implant that's just a few millimeters thick, less than a centimeter thick, and it goes on the end of the bone to recreate that cushioning surface between the two bones that are rubbing together. So we put a metal cap on one side of the knee, the femur bone. We put a metal cap on the tibia side, the bottom side of the knee as well, to resurface those bones, and then to recreate that gliding surface that the cartilage would create. We put this plastic liner in between them, and that creates this nice smooth surface with the end of the bones recapped or resurfaced, so that knee can now glide nice and smoothly. In addition, oftentimes we put a plastic button on the back of the kneecap there so that it glides nice and smoothly back and forth. So while it still is a major surgery, it's often not as major and invasive as what some patients imagine a knee replacement to be. Knee replacement is a great procedure in the right patient that has arthritis. We can oftentimes get patients back to almost all normal activities, normal daily activities. I would hesitate to say that we're going to convert you back into a 20-year-old again and make you go out and be able to dunk a basketball or things like that with a knee replacement. That's not the goal, but the goal is to get you back to a functional level with minimal pain and being able to do most daily activities that most people enjoy. Now, we do have people that get knee replacements and they can still take the blue runs on a ski resort or go out and hike, or the common thing now is playing pickleball. There are patients out there with knee replacements doing that, and we enjoy that. We want that to be the case because our goal in doing it is to keep people active. But not everybody is going to be able to return to those types of activities, so it's important to keep that in mind. It's not a fountain of youth or anything like that. I do want to talk a little bit about some of the advancements that have happened in knee replacement over the last 10 to 20 years, and hopefully quell some fears about the knee replacement procedure, because we have made quite a few advancements. One of the biggest things that we've been able to do is improve our anesthesia. Working with our anesthesia colleagues, we've been able to control the pain both before and after and during the surgery much better, to create a much smoother experience for patients. When I started my training in orthopedic surgery, knee replacement patients would stay in the hospital for at least 3 to 5 days. Then they would usually go to an outpatient rehab center for at least a couple of weeks, usually with drains and pain pumps and taking all kinds of narcotics and things like that. To the point now where most of my patients, after we do a knee replacement, leave within hours after the surgery, and they go and sleep in their own bed that night. And a lot of times we do physical therapy either at their home or in the outpatient therapy setting, and they're walking around their house day one after surgery. Some of my patients really don't even need narcotic medications anymore because of the advancements that we've made with our anesthesia colleagues and pain control and the way that we do the surgery. So it's come a long way. Not every patient is going to experience the same experience with knee replacement surgery. Of course, everybody reacts differently, but it is much more common that we have these really better recoveries, especially in the early going after knee replacement. In addition, we've had improvements in our implants. A lot of people worry about how long the implants will last. Will there be some kind of wearing out process where they have to go and have another surgery in the future? Our implants are better than they were 20 years ago. The plastics involved used to wear out. Now they essentially don't. They're really slated to last anywhere from 25 to 30 years plus. And so for most patients, barring any significant complication in the rest of their lifetime with that knee replacement, whether that would be an infection or a fall with a fracture or something bad like that to happen, we really expect most of these knee replacements to last for the rest of the patient's life, with a small percentage of patients eventually needing a redo or a revision surgery. So our implants have improved. On top of that, the way that we put those implants in has improved. We've become more accurate, more precise, and oftentimes most surgeons, including myself, create kind of a personalized alignment of that knee implant to fit that individual patient. It's no longer one size fits all and one implant fits all for each knee surgery. And that introduces the concept of robotics. A lot of times we use robotics now in knee replacement surgery to more precisely and accurately put in that knee implant so that it functions more like your native natural knee before it started having arthritis and pain. And that makes it feel like a more natural knee replacement once it's all healed and everything like that. So we've come a long way. One of the biggest advancements for me in my own personal practice is the approach that I use to actually do the surgery. Now, in hip replacement surgery, many people are familiar with the difference between a posterior approach and an anterior approach. Again, for years and years, decades long, pretty much everybody used either a posterior or a lateral approach for a hip replacement, and in more recent years, a lot more surgeons are using this anterior approach. And the hype or the excitement about that is through an anterior approach, you don't cut muscles. You just push them out of the way, and then you put the hip implant in. In knee replacement surgery, the vast majority of surgeons, including myself, were taught to use a traditional approach into the knee that actually has to cut into some muscles and some tendons. So when we would make this incision over the front of the knee, and to get inside of the knee to be able to put these implants in, you have to be able to move the kneecap out of the way. So what we would do is we would cut up the side of that kneecap and then come around it. And this model doesn't have it, but there's a muscle in our leg that comes in and attaches right on that inside part of the top of the kneecap there. Well, in order to be able to move it out of the way, we were taught that you have to cut into that muscle and into this tendon to be able to mobilize it and move it out of the way so that you can get your implants in and be able to see everything that you need to see. Fortunately, in the last year or so of my practice, I have been able to receive more education from certain surgeons that are using an approach that doesn't cut that muscle and doesn't cut that tendon. The fancy scientific term for it is a medial oblique modified subvastus approach. Now that's a mouthful, right? Nobody wants to go around and say medial oblique modified subvastus approach all day, every day, over and over. So it has a variety of names out there on the internet. The catchiest one that I had come across that most patients are able to recognize is called Jiffy knee. So some people have heard of Jiffy knee, but Jiffy knee is just an easier to say name for this modified oblique or medial oblique modified subvastus approach. I even messed it up saying it there. So, and that is really nice because you're not cutting into the muscle and the tendon. And we're still able to do the same knee replacement procedure with just less trauma to those soft tissues. Now, since I've been doing that, I have seen much less pain, much faster return to activity, much less narcotic use after knee replacement surgery. And so that has been a huge factor in me, in my practice, and a huge change in that early recovery period for my patients. I've been very pleased to see how those patients are doing now. So I've been really excited about that. Relatively simple, but significant change in that knee surgery. And most of all, my patients are much happier and excited about it too. So that's always a plus. And so those are some of the advancements that we've had. Between the approach, the robotics, the implants that we use, things have improved in knee replacement surgery. And now in the right patient that has tried other things but has bad arthritis that's limiting them, it's a great procedure that can get people back up on their feet and really improve the quality of their life in those later golden years, as they're called. So that's more or less what our treatment options are and some of the advancements that have been made. So now I want to take a little bit of time, and we've had some questions come into the comments section. And I want to go through some of them because I think some of them, as I was watching them pop up, some of them are really common questions that we have patients ask in our office. So I want to be able to go through some of them. So I have some assistants here that are going to help me go through these questions. You'll hear them ask the questions, and then I'll be able to answer them.
Perfect. Do robotics really make a difference in knee replacement?
That is a great question. So there are proponents of robotics and there are antagonists of robotics. The truth of the matter is it's going to depend on the surgeon. It's going to depend on how they use the robot. It's going to depend on the patient case. What I can say is there is a lot of evidence that we put implants in much closer to our desired plan when we are using robotics. There are many, many scientific articles that show that we are more accurate and precise when we use robotics. Now, there is a little bit of a mixed review in the scientific literature about does that translate into a better, overall outcome for the patient. That could be measured at 6 months, 1 year, 2 years. And some papers out there say that robotics really improve that overall outcome, and some say that it doesn't necessarily make a big difference. What I will say is the ones where it's not making as big of a difference, they probably have one of those really, really gifted surgeons doing those surgeries, because it just makes more sense to me that if you're using technology to back up your own, procedure and alignment and techniques, the outcomes should be better. I personally feel that robotics make me a better surgeon. It allows me to put in implants in a more precise manner with less tissue damage and things. And I've been really happy with the outcomes that I have seen from the robotic system that I use and the implant that I use with it. So,
how do I know if I need a knee replacement?
The biggest way to know if you need a knee replacement is to talk to an orthopedic provider, a joint replacement specialist, about your knee. You can evaluate, your history, your symptoms, where it hurts, when it hurts, and look at imaging like x-rays and things. I try really hard to show patients their x-rays and really explain, this is where the arthritis is, and this is, where we can see it progressing and things. And then on top of it, if you have arthritis, the first thing to try is those simpler measures like injections or activity modification or things like that. But if those things aren't working and you do have bad arthritis, usually the next consideration is a knee replacement. And that's just something to talk about with your doctor and the specialist.
Do you recommend using the robot on younger patients compared to older patients, or is there no difference?
That's a great question. So I think robotics, and if we're treating a younger patient that has developed arthritis, one of the key factors in that knee replacement lasting a really, really long time is that it's put in as precisely and in the right position as it can be. You can think of it as the alignment of a wheel on your car. If that alignment is off, eventually that tire is going to wear out and have issues. the concept is similar in the knee replacement. If you can put it in perfect alignment and have it, function as a normal knee, that's when we have the best chance of that knee lasting as long as it possibly can. And I think that robotics do offer that precision in those patients. So if it was me, my opinion would be yes, that I would use a robotic, especially in a robotic system, especially in a younger patient. But I use it in all my patients, so I guess I'm biased.
Can robotics be used in knee replacements that have already been done but need more surgery?
That's a great question. So in the recent last couple of years, there has only been one system that has been FDA approved to do what we call revision knee replacement. That means they've had a knee replacement, for some reason it's failing, and they need a redo surgery to fix that knee replacement. There's like I said, there's only one FDA approved robotic system that is out there for that. Fortunately, it's the one that I have chosen to use. But some of the other systems, they will allow their surgeons to use them what's called off-label. So, they're using some techniques. It's not the official FDA approved technique, but they work essentially the same and do create great outcomes. Me personally, I feel like the utility of revision knee replacement with robotics is even greater than in what we call primary knee replacements, simply because that patient has already had something go wrong with their knee replacement. We want to make sure that we're doing the best job that we possibly can so that they don't have to go on to have more and more and more surgeries. So it's really important to get that revision knee replacement just right, and robotics, I feel, do help with that.
Okay, this is a combination of two questions, or two comments. The first one says, I have heard horror stories of people getting knee replacements, and it makes me scared to consider it. How has knee replacement improved or changed over the years? And the second question is, I've had my right knee replaced twice and have had some problems. Now my left knee needs replacing. What are some of the new techniques?
Yeah, so the things that we've kind of been talking about as far as the robotics and the implants and things. So one thing I have to say, and I say this to all my patients, I'm a human, the patient's a human. When two humans are interacting, there's always a chance that things aren't going to work out the way that we plan. Every surgeon that's ever done surgery has a patient that has had a complication. It's just part of the human existence and doing surgery. So we can do surgery the best that we can. We can use all the technology and the best techniques and the protocols, and we'll still have patients that unfortunately don't have the results that we're desiring. And so I'm sorry to that patient, to the person that wrote in and said, I had a bad experience with one knee and had to have multiple surgeries, or you've heard horror stories. Yes, those exist, and they keep us up at night as surgeons, which is why we try to use all these things to avoid those situations. But with our advancements in our protocols, with it, not only from pain management to anesthesia to the approach to the knee where we're using muscle sparing techniques, to the robotics and everything that we've been talking about, we're getting as good as I think that we possibly can with the limitations that we still have in our day and age. Are we going to continue to search after improvements? Absolutely. But we're making progress. I do believe that. And so we've been talking about these things that can help, and I do think that they do help. So,
how long do knee replacements last?
As I mentioned, so with our new materials, the official statistic is that over the course of 25 to 30 years, we expect 1% of patients per year to go on to have revisions. Now that includes all causes of needing revision surgery. That can be infection, it can be a fall with a fracture, it could be any other reason why they would need more surgery on there, not the knee replacement, not just the knee replacement wearing out. If you really just hone in on the knee replacement wearing out for whatever reason, that number is quite low, less than 10% at about 20 years. And so we watch that data continue to go out to 25 and 30 years. As we continue to watch it go out, that number still remains very, very small. So with our modern implants, we say it should hopefully, if we're doing things right, and you're kind of the average age to have a knee replacement, we're hoping that it lasts you for the rest of your life.
During surgery, what are some of your own techniques you use to improve sterility and less chances of infection of the implant?
Yeah, so sterility and infection is kind of our, avoidance of infection is our main goal, because infections are terrible outcomes when they happen. We try everything that we can to avoid them. So there's a whole host of things that we do from the days leading up to the surgery, to the time that you're in the pre-op area, to once you get back into the operating room. We have all these protocols that we follow. We wash the leg several times with antimicrobial substances. We put sterile drapes over it. We use another sterile drape to help keep any bacteria off the skin and things. We use solutions during surgery to kill any bacteria that could possibly be in the inside of the knee. We use antibiotics before and after surgery to try to prevent infection. We use special dressings to try to prevent infection. We do all kinds of things to try to prevent infection. Thankfully, with those measures that we take, infection rates are usually pretty low. National average is 2%. My personal incidence of infection is less than the national average. At about 1% of my patients have had an infection that I've treated. And so we're always working on continuing to improve those protocols to decrease the chance of infection. But again, we're humans, and sometimes infections will still happen no matter what we do. And so we're trying to always look out for that and do everything that we can to avoid it.
I've heard that injections can actually make arthritis worse. Is that true?
I'm sorry, I didn't say that again.
Yep. So I've heard that injections can actually make arthritis worse.
Oh, injections can make arthritis worse. So there were some studies that came out when I was starting my training that indicated that maybe having too many steroid injections into a knee actually accelerated the progression of the arthritis. Unfortunately, a lot of those studies didn't take into account some of the factors that can cause arthritis to progress, and so they didn't do as much of a rigorous study kind of controlling for those different factors to see if that steroid injection actually was making the arthritis worse over time. My personal opinion on that is arthritis is going to progress whether we do injections or not. We need to be careful about making assumptions like that. And in the end, what we're trying to do is control symptoms for as long as we can. Now, again, if those injections aren't working and you're not getting pain relief, we're probably going to recommend that we go a different direction anyway. But there are some patients that, they'll get one injection a year and it staves off the inflammation for that long, and they're able to continue to function. And if it were my knee, I would say, hey, if I only need an injection once or twice a year and I can continue to function without pain, I would do that until it didn't work anymore, just to avoid surgery if able to. So my own opinion is that we do things to try to help people, and if they're not working, then we'll consider other options.
Okay, and the last question for now says, do we still need to take blood thinners after knee replacement?
Yes, so anytime you have a major surgery on a lower extremity, there's a chance that you can form a blood clot in the deeper veins of your leg. And those can be quite painful, and they can also break off and go up into your lungs, which can cause even worse problems. And so in order to avoid those types of blood clots, we use blood thinners. We have made some changes in our protocols over the years of that. Now, typically, most joint surgeons use a baby aspirin twice a day for a few weeks after knee replacement surgery, unless you have some other major risk factor for having a blood clot, and then we may consider using other medicines. But typically now we just use a baby aspirin, and that is good enough at preventing the vast majority of blood clots after surgery. So we had some more questions in the chat. We will try to go back and write answers to those. Thank you for everybody that's participating. I love talking about this stuff. I will try to go and answer all your questions. Again, if you do want to come and have a consultation with me or a visit with me and ask me these questions or have me look at your knee, I'm always happy to. Our clinic is at Holy Cross Jordan Valley, and as well as at Holy Cross Mountain Point. If you want to call to set an appointment with me, the phone number for our office is 801-568-3480. And again, I'm Dr. Sagers, so if you ask the front desk for an appointment with me, they will set you one. I want to thank everybody for coming. I want to remind everybody, again, those disclaimers that I said at the beginning. Nothing that I said here can be considered personal health advice. You need to consult with your medical doctor about your symptoms and treatment plans. And also, none of the opinions or things that I said here represent an official endorsement or opinion of Common Spirit as an organization. But I thank you for your attention. I look forward to interacting with you on the Facebook chat and hopefully seeing you sometime in our office if you need me. So thanks again. Have a great night, everybody.